Well, hey everybody, my name is Kevin, paramedic practice educator on Vancouver Island. And today I just thought I'd take a quick second to talk about an aspect of cardiac arrest management that sometimes is applied maybe inappropriately. So we're just going to talk it through. I'll let you know what I think. It's going to blow your mind or not. Anyways, we're going to go through it anyways. I just want to talk about checking a blood sugar and administering dextrose in a cardiac arrest situation. So I think what can happen a lot of times is after a cardiac arrest is started and ongoing, if your CPR going well, 2 minutes, good depth, good rate, your ventilations are appropriate with a BVM or a supraglottic device or an endotracheal tube, whatever, and everything seems to be functioning, sometimes what happens is people are looking around for something to do. It gets a little bit sort of mechanistic just going through the process. Yeah, there's lots going on, calling EPOS or a paramedic specialist, dealing with family. There's a lot of different aspects, but sometimes it just gets a little bit routine after the first 5 or 10 minutes. And that's usually when I see people start to think about, well, maybe we should check a sugar, especially in somebody who might have a diabetic history. One of the issues with checking a sugar, there's kind of two main issues actually with the sugar thing. First of all is the actual capillary sample itself. This is probably going to overestimate hypoglycemia. And what we see is there's been some studies and there's been some investigation into this that show that in a low flow state like shock or in cardiac arrest, you can actually overestimate hypoglycemia. What's the problem with that? The problem with that is then people tend to want to treat it. And a lot of times the administration of dextrose, let's say you've started an IV and you get a low blood sugar reading 15 minutes into a cardiac arrest, you might say to yourself, hey, I think I'm going to give some dextrose because that could be a treatable cause of cardiac arrest. That's a pretty reasonable thought. The problem with it is that actually hypoglycemia was removed by the American Heart Association as one of the treatable causes of cardiac arrest, I think back in 2010. And it's not actually an indication for treatment in a cardiac arrest as a cause of that arrest. So I talked briefly about the problem associated with the capillary sample. The next problem is that if we do treat and we give some D10, or if ALS gives some D50 or whatever, if we give some dextrose, there's kind of some problems with dextrose administration relating to the cardiac arrest specifically. The problem is that when we give dextrose, what happens is that sugar in the solution is actually very quickly drawn out of the solution, out of the fluid, and into the interstitium and into the cells. It goes away very quickly. What we end up with then is just pure water sitting in the veins. Think of it that way. The sugar's gone, this ends up being just pure water, or what we might call a hypotonic solution. So normally in blood vessels, we have a balance. There's a balance of sodium between the blood vessel and the interstitium and the cell. There's a balance of water because water follows sodium through osmosis. Water likes to move from an area of a low concentration of solute, like sodium for instance, to a high concentration of sodium. It likes to move. If everything is equal, like we can see here, then what we see is that there's not a lot of water movement or just sort of normal amounts of water movement within the cells. If we give a bunch of what ends up being basically free water, because that dextrose goes away very quickly out of that D10 bolus, like say you give a bag of D10 to somebody, all of that free water now shifts that a little bit. And what you end up with is you end up with a relative deficit, so to speak, of solute in the blood vessel. And you can see that here. Is what we have more water in relation to the amount of, say, sodium in the little green dots. And that allows water to start to move to the area of higher concentration because water moves pretty freely everywhere. So in this case, the water will actually shift into the interstitium and perhaps into the cells. The problem with this is that this means all of that water, instead of being nicely in the blood vessels, is actually in the interstitium, causing edema. And when that's in the brain, in the setting of cardiac arrest, where there's a lot of other reasons why you can have edema, that additional fluid can contribute to the problem and can lead to worse outcomes. There's actually a study done in about 2015, I want to say, as I think off the top of my head and try to remember what's on my computer at home, that actually shows a worse outcome with dextrose administration in cardiac arrest. And they did a registry study of like 100,000 cardiac arrests, and they looked at it, and they saw that people who got dextrose administration tended to have worse neurological outcomes. And so that's another reason, and maybe speaks to the mechanism I just spoke of, as to why we don't want to give that dextrose in cardiac arrest. So I hope that helps a little bit. If you have any questions, feel free to reach out. But the basic part of this is that we don't need to check a capillary blood glucose in cardiac arrest because we don't really want to give dextrose in cardiac arrest. So we don't need to do it. Even if a patient has a diabetic history, that's unlikely to be the cause of the cardiac arrest, and it's not even in the AHA guidelines as a treatable cause of cardiac arrest. Post-arrest, if you get ROSC, absolutely check a sugar. Most patients tend to trend a little high after cardiac arrest as their body figures themselves out. But, you know, like after you get ROSC and you're transporting to the hospital or whatever may be, is definitely check a blood glucose then as part of your vital signs. And if it reads as low, you might want to consider just chatting with the PS or EPOS before you go ahead and give that bolus of dextrose, just because of the things we highlighted. So it might be worth a chat. You wouldn't be wrong to do it in that situation because you have ROSC in a hypoglycemic patient, but there could be some downstream consequences that we don't really want to, that we might want to avoid. So I hope that helps. Think about sugar checks and cardiac arrests. That's all I got, and I hope you have a good day. Talk to you later.